Please call the meeting to order.
Okay. Good afternoon and welcome to the Joint Conference Committee for Laguna Honda Hospital for October 10th, 2023. Mr. Secretary, will you please call the roll?
Sure, I'll start with you, Commissioner Guillermo.
Present.
And Commissioner Green.
Present.
I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. Item 2 on the agenda is the approval of the September 12, 2023 meeting minutes.
Thank you. You have the minutes before you. And may I ask for a motion to approve?
So moved.
Second. Is there public comment?
There is public comment. Folks on the line, we have two categories of public comment. One is the folks who've received a waiver for disability, and 2 people have received that. If you are one of those people and would like to make comment, please raise your hand now. I see 1 hand, so I will unmute that person. Hi, caller. Please let us know that you're there.
I am. It's Patrick Manetshaw, code AA.
Thanks, Mr. Manetshaw. You've got 3 minutes.
All right. Thank you, Mr. Morowitz. The minutes report that Mr. Pickens indicated resumption of admissions to Laguna Honda are being delayed because of the shortage in activity therapists and food service handlers. That's concerning because Laguna Honda's patient census is 226 fewer patients than it had in December 2021 before Laguna Honda was decertified. The vacancy reports by FTE show Laguna Honda has 2.5 FTE fewer food service worker vacancies across various job classification codes in October 2023 than it had vacancies in December 2021. There were 8 food service worker vacancies in December 2021, and now there are only 5.5 food service worker vacancies now for 2.5 FTE fewer vacancies. Laguna Honda now has 6 more vacancies in activity therapists across job classifications 2586, 2587, and 2588 than it had in December 2021. 11 vacancies in 2021 and 17 vacancies now. But with 226 fewer residents, short staffing is a bogus reason to delay resuming admissions. And what's the status of hiring Laguna Honda's medical director? That recruitment has been ongoing since at least January of this year. That position needs to be filled quickly. Thank you.
That is the only public comment for this item.
Thank you. I'll call for the vote. All those in favor?
Aye.
Aye.
All right, thank you. Item 3 is general public comment. At this time, members of the public may address the Laguna Honda Joint Conference Committee on items of interest to the public that are within the subject matter jurisdiction of the JCC, but are not on this meeting agenda. Again, please raise your hand if you'd like to, by pressing star 3 if you'd like to make public comment. I see 1 hand. Mr. Manetshaw.
No, I did not raise my hand for this item. Sorry, Mark.
Okay. Then I see no hands for this, commissioners, and we can move on to item 4, the executive team report. Lucia, please bring that up.
Thank you, Mr. Pickens.
So good afternoon, commissioners. It's my pleasure to be here with you this afternoon. I'm joined here in the chambers by Dr. Nita Ratana-Wangsa, who is our interim chief medical officer at Laguna Honda, and will be providing a separate report to you on the agenda today. Next slide. In addition, we have members of the executive staff who are joining us remotely and will also be able to help answer any questions or provide additional context if needed. I'm pleased to report that very early this morning, I met at the front door and welcomed our 2 new directors of nursing at Laguna Honda. We are thrilled to have them on board. Today was their first day, Ms. Tracy Brown and Mr. Michael Collins. As we said in our announcement, the pilot project we embarked upon at the recommendation of our consultants several months ago of a traditional nursing home model of having directors of nursing. We found that to be useful and have now employed that for our current permanent structure. Each of these individuals, Ms. Brown will be director of nursing for the North Patient Care Tower, and Mr. Collins will be director of nursing for the South Patient Care Tower. So we think this is well in alignment with all the work we've done over the last year and a half to really bring Laguna into alignment with traditional best practices within skilled nursing. Each of them will partner with one of the 2 assistant nursing home administrators, and they will all report directly to our new nursing home administrator, CEO, Sandra Simon. So again, we welcome them both and look forward to getting them integrated into the Laguna Honda system. Next slide. Just want to update on recertification. As you know, we previously submitted an application for change in status as we were directed by CMS in August. And then as the application was being reviewed, CMS contacted us and indicated that we should actually submit a brand new application. So on September 15th, we submitted the application for a new CMS provider agreement for Laguna Honda. That application itself has been approved by the CMS intermediary and has been forwarded to the California Department of Public Health. And we are now waiting for California Department of Public Health and CMS to actually show up on site for our full-fledged CMS Medicare survey. Again, we're expecting that survey any day now, and we maintain all of the survey readiness activities we've deployed over the past several months in anticipation of that survey. Next slide. Accordingly, we were anticipating that Medicare survey we thought it would have happened prior to now, and hence we did a temporary pause in the reporting out of our milestones related to the various action plans. Given that with those instructions from CMS to resubmit a new application, that extended the process. So we felt it was prudent to end that pause in our milestone work and return to focusing on the milestones, getting them completed and underway. There are 119 milestones that remain outstanding, and we have a action plan in place to have all of those milestones completed by November 3rd of this year. That is a huge undertaking. At last count, once those 119 milestones are completed, that will give us a total of approximately 960 individual milestones that have been established and met since January of this year regarding CMS recertification. Next slide. And wanted to share with you an acknowledgement, external acknowledgement of the good work being done at Laguna. Most recently, California Department of Public Health recognized Laguna for being among the top 7% of all California nursing homes that completed their newest 4-session of infection prevention and control train-the-trainer workshops. Again, particularly given the size of Laguna, it's important that we have appropriate infection prevention and control procedures. You'll recall that those issues were the ones that truly led to the initial decertification in April of 2022. And so just wanted to give you reassurance that this particular area of operation continues to be a focus at Laguna, and the staff are continuing to increase their knowledge and awareness of infection prevention and control measures. Next slide. And finally, just giving you our most current stats through September of 23 in terms of admissions. As you know, we've been on an admission hold and continue on that hold over the next few weeks as we go through Medicare certification and then validation of all of our improvement work to make sure that we can sustain regulatory compliant operations before we begin to accept new referrals and new admissions. And happy to answer any questions that you may have for me or other members of the staff. And again, thank you for the opportunity to be here today.
Thank you, Mr. Pickens, for your report. Is there public comment?
Sure, I see one hand. And folks, again, we are on item 4. If you'd like to make comment, I'll unmute that person. Mr. Manette Shaw, you've got 3 minutes.
Hi, I think this is Dr. Palmer.
Oh, I'm sorry. Hi, Dr. Palmer. I apologize.
Hi, but I've got the permission. One of the things I wanted to ask is there were up to 45 patients that required discharge out of Laguna Honda to another level of care. And last I heard, only a minority of them had been discharged. There were initially 38 and then 6 or 7 more. And I haven't heard anything about them. And were beds found for them? What happened to them? And are there enough services in the community to discharge people that do not or should not be at Laguna Honda? Thank you.
All right, thank you. And let's see, there's one more, I believe. All right, caller, please let us know you're there. Yeah, Mr. Manette Shaw.
Yeah, it's Patrick again. On slide 2, while it's good hearing that Tracy Brown and Michael Collins have been hired as directors of nursing, presumably for the top positions in the north and south patient towers, there's no information on whether their nursing experience is actually in skilled nursing facility settings. What's more, the city controls payroll database for the fiscal year ending on June 30th of this year does not list either person as having been employed by SFDPH in the last fiscal year. Why weren't these 2 positions filled as promotions from within Laguna Honda or SFDPH? Do either of these 2 people actually possess skilled nursing facility experience? And if so, for how many years each? How familiar are they with CMS's FTAG system applicable to SNFs to show that they have great understanding of skilled nursing facility regulations? On slide 5, the infection control slide, the recognition from your consultant HSAG is essentially meaningless, given the millions that have been paid since May 22 as your in-house consultant to fix Laguna Honda's myriad slew of problems around infection control. Indeed, comparing the monthly quality affairs reports for 2022 compared to 2023 shows that Laguna Honda has had 3 more disease outbreak infection control related facility reported incidents in 2023 than Laguna Honda had in 2022. I would not be bragging about Laguna Honda's quality of infection control and prevention. Thank you.
All right, that has all the public comment for this item.
Thank you. Are there any questions or comments? Commissioner Green.
Well, thank you for the report, and we're delighted that you have these very experienced individuals working in nursing in the towers. I was wondering, assuming we pass the survey, which hopefully will happen soon, what do we anticipate in terms of future surveys? And also, what about our CCBMs? And, as we try to transition to independence, I'll call it, is there any timetable? Is there anything about survey results, even we pass it, there's usually, some advice or some corrective actions that they mentioned. So what do you foresee as kind of our new steady state? And especially when we're going to be able to wean off of some of the additional support we have?
Thank you for that question. We have been addressing those issues very much over the past several weeks, and in fact intend to come to the JCC next month and present to you our best thinking in terms of what we're calling a sustainability plan that addresses how do we move out of an incident command structure into regular operations. That plan will include several of the initiatives like the CCBM initiative that was actually the newest of all the initiatives we put in place over the last 18 months. Our thought is that initiative has been extremely helpful and successful in being able to quickly and proactively identify regulatory and patient safety issues. So we definitely plan to continue the CCBM initiative for the next several months into the next calendar year. And then as we see as additional surveys happen over that time period, and as our own key performance indicators will tell us, I think it'll help give us an idea of when we begin to sunset that program. It was never meant to be a permanent process. It was always envisioned to be an extra boost and support of experienced directives of nursing and skilled nursing at the institution. And so we will continue that for a few more months, but then are looking at not only how do we take the best components of that program and embed it into regular operations, but also, as you know, we do tons of rounding. We do 6,000 independent observations per week. We have to figure out how do we go from that to regular operations. Much of that work has been supported by consultants, so those will go away. So we're in the process of putting that all together and plan to share that with you at our November meeting.
That's great. We will really look forward to that. And do you have any sense, and you may not, whether the fact we've been through all of this and we've been under a microscope, do you think once everything is sort of settled that they'll look at us like any other skilled nursing facility in terms of cycles of surveys? Or are they going to be, still, are we going to be under heightened scrutiny? Do you have any sense of just any sense of what will happen?
Yeah, I don't have a crystal ball, but my sense will be we will continue for a while to be under scrutiny. I mean, this has been a traumatic event for everyone involved, for our residents, our staff, our families, the community, our organization, and also for the regulators. So I can't imagine that anyone would want to take the focus off of Laguna anytime soon, which is why we are being very thoughtful and methodical as we plan this transition from incident command to regular operations, anticipating that continued intense scrutiny, although particularly consultant resources, will disappear. We want to make sure then that we have vacant positions filled so that there is sufficient trained and accountable employees in place to carry, I think, the intense scrutiny that we know will continue in the future.
Thank you. And where are we on helping individuals who no longer require skilled nursing to find new placement? I know we got a somewhat encouraging report at the commission last week from our behavioral health division about expansion of beds and so forth. So are any of those changes and expansions going to help? I know we've been incredibly thoughtful and thorough in trying to research the best placement for individuals who don't qualify. And I know that's a tremendous amount of work in the context of all the other work, but I'm wondering how things are and whether these changes are going to help.
Yeah, happy to give an update. So you mentioned the Department of Public Health Behavioral Health Services. So we are fortunate that they have actually deployed their team that facilitates placements to lower level of care, actually at Laguna. So they work with our staff. Claire Horton is our lead, the CMO for the network. She works directly with the care coordination staff at Laguna and with the Department of Behavioral Health's community referral unit. So they're constantly looking for those residents who no longer have skilled needs placements in the community. There were actually 2 discharges last month of individuals who no longer required skilled nursing. There have been a total of 12 since April of last year. As you can imagine, there are challenges in finding placements, but we have a very robust process in place now. We partner with the city's Department of Homelessness and Supportive Housing and the city's Department of Aging and Adult Services. They are all at the table at Laguna. All organizations are working to find placements. I looked at the list today. There are a couple of folks who have had placements identified. They're waiting on things, for example, like to get durable medical equipment installed in the home before they can leave Laguna. Another one, they're waiting, the unit's been identified for them. They're just waiting to get the keys. So people are at various stages in the process. So we feel confident that while it's a slow process, because we want to make sure that we're putting people in safe environments as they transition out of Laguna. And remember, as they transition out of Laguna, that opens up the door for individuals on the other end who still are in need and are looking for a skilled nursing bed. So I think it helps the entire continuum of care and flow for all the hospitals in San Francisco.
Wonderful. Thank you very much.
I just had a quick question about the 2 new nursing directors. First, congratulations on being able to greet them on their first day today. And clearly, the summary of them shows that they have a tremendous experience and such. I was wondering, though, in terms of the experience that they have, this sort of new interdepartmental, sort of cooperative, collaborative approach to nursing and patient care, do they have experience with that? Will they be able to lend that experience to that whole sort of new way of working together?
Absolutely. Both of them are extremely experienced, skilled nursing facility directors of nursing. Ms. Brown actually worked her way up through the system. She started as a nursing assistant, then became a licensed vocational nurse, and then a registered nurse. In addition, she also served previously as one of the surveyors for the California Department of Public Health for skilled nursing. So she knows the regs. She has a track record of going into troubled facilities and actually turning them around. So that was one of the things that made her a very highly sought after candidate. Mr. Brown also comes to us as experienced.
Mr. Collins?
Mr. Collins, Michael Collins, comes to us as an experienced nursing home director of nursing. And also he's worked in other areas, including acute care. As you know, we have an acute care unit at Laguna. He spent much of his career in the U.S. Army. So he comes from a military background, but in the private sector has worked almost exclusively in long-term care and nursing operations. And he has a focus in clinical education and training. And the other thing, Tracy Brown also comes to us as a certified wound care expert. And that's extremely important, as you know, in a skilled nursing facility. So, and so they both, coming from traditional nursing home backgrounds, have really grown up within that whole collaborative interdisciplinary team approach that Sandra is bringing to Laguna. And so we feel confident they will be fit in well and really complement particularly the newest changes and improvements that have been put in place.
Well, thank you, and that's very exciting, and I really look forward to seeing the contributions that they'll make along with all the sort of new pilots and other things that are going on at Laguna Honda, particularly as we look forward to the stability and sustainability efforts that you mentioned. So thank you for that. If there are no other questions or comments, we can move on.
Thank you. Item 5 is the hiring and vacancy report. Let's see, who's going to be, let's see, I will unmute.
Thank you. Good afternoon, Commissioners. Laguna vacancies and open positions hovered around the same levels that we saw last month. We had 10.9% vacancy rate in August, saw a nominal rise to 11.1%. We've hired a total of 27 employees between September 1st and September 30th in various classifications and had 2 separations during the same period with no retirements. We continue to prioritize and support with the hiring of the RN class. The vacancy rate currently stands at 9.09% for the month of September 2023, which translates to 19.5 vacancies. Of these positions, we are in the midst of processing 7 reassignments. We have candidates moving through the interview process in 8 of these positions. And for the rest, we're supporting hiring managers to initiate the hiring process. With regards to nursing managers, the 23-24 classification, we currently are in the process of completing reassignment with 1 position, scheduling interviews and selection for the other 3 open positions. 2 nurse manager hires are currently onboarding with start dates towards the end of this month. There are currently 17.65 openings for the licensed vocational nurses category or the 23-12 class, for which the staffing team is working with the merit team on exam administration. With the certified nursing assistant category, classification 2303, last month we onboarded 32 new hires into this class at Laguna. Human resources team is also continuing to develop the batch hiring process and currently focusing on the health worker classes 2586, 2587, 2588, the 2903 or the hospital eligibility worker classification, and 2930 or the behavioral health physician classification classes, where we see continuous demand for talent across locations. They're all being supported with batch processing, which saves time and increases efficiencies in the process. HR continues to conduct regular vacancy meetings with program hiring managers to review their ongoing hiring needs. RN highlights from last month, 5 2320s and 6 P103s started last month. Thank you.
Thank you. Is there public comment on this?
Yes, there's one hand. Folks, we are on item 5, just for you to know. All right, I've just unmuted the caller. Please let us know that you're there.
I am. It's Patrick again.
Please begin. You've got 3 minutes.
Thank you. The FTE report shows that the 2302 and 2303 job classification codes for CNAs and patient care assistants classification are being combined again. I thought Dr. Chow had specifically requested in the recent past that they not be combined in these vacancy reports by FTE. After all, they're listed as separate line items in the annual salary ordinance. Comparing today's vacancy report dated October 23 to the same report for August 2023, 2 months ago, shows the total number of budgeted FTE positions dropped by 14.3 FTEs in just the last 2 months, from 1,485 in August to 1,471 in October. Why was there a drop in the total number of budgeted FTEs across just 2 months? Both should have been based on the annual salary ordinance passed by the Board of Supervisors for the current fiscal year. By contrast, the December 2021 same vacancy report by FTE showed a total of 1,443 total budgeted FTEs, which was only 27.3 FTEs less than today's report of 1,471 FTEs. After all of this expense with the consultants in the last 2 years and your claims of hiring additional staff, why is there only 27 more FTEs now than there had been 2 years ago? Doesn't seem like those positions that have been added are going to adequately reduce the number of substandard patient care violations. And it's not even clear that you're hiring in the right job classification codes by FTE to prevent that substandard care.
Your time is up, Mr. Minetshaw. Thank you. All right, that's the only hand for that item.
Okay, any questions? Yes, Dr. Gray.
Yes, thank you for your report. I do have a quick question, which is, I think we're very interested in ensuring that especially our leadership in nurse management in particular is well filled. And I know the 2322 category is a nurse manager, but I wonder if you can clarify two things. What category, do you categorize charge nurses and nurse managers under the same classification? And what are the numbers? Because these are always given to us based on vacancies. There's certain ones I know I'd like to look at, and sometimes look at me, I can't remember.
Sure.
So if you could clarify, it'd be great. And then also, what about the coaches? Because that's always been something that has been of concern recently, and I wanted to know if they fall under the 2303 or where in this list of job classifications they come.
Absolutely. I'll start and then I'll ask Terry D'Antoni, who I know is on, to take over. So charge nurses are not in the same classification as nurse managers. They are the 2320s, the regular RN classification. So there are RNs who get an additional assignment as a charge nurse. In terms of your other questions, I'll have Terry address those.
Good afternoon, commissioners. So Roland is absolutely right. A floor nurse is a 2320 and a charge nurse is a 2320, and they get a stipend or a premium to be a 2320. A nurse manager is a 2322. They're in a different union and they're in and that's their classification. They're the nurse managers, and a 2324 is a nursing director, also in Teamsters.
Thank you. And then the coaches, they're 2303s.
2303s, yes. And there are some HHAs who are CPR certified and trained that can do coaching.
And if we wanted to get a better understanding of especially adequacy of charge nurse position, especially since some of them do fill in for managers when there isn't someone there, how could we follow that? How do we kind of get a better idea of how we are doing with both the charge nurses and the nurse managers? And I ask simply because when the monitors leave, it's going to be so critical that we have that continuity, and also that you don't have a lot of turnover in those particular positions, since they will have a lot to do with continuity.
Right. And so currently I have 4 units now that have charge nurse standing up as nurse managers in the tower, and 1 in the Department of Care Coordination. We are actually interviewing this week is our plan for nurse managers. I have a list, and our new DONs, along with Sandra, will be interviewing for those, so we can fill those. 1 or 2 of them, you know, some may come from the pool that are in now, the charge nurses for a promotive opportunity. I haven't viewed the list to know the names. So that'll be done. And we do have a list of charge nurses, and they do stand them up. It's interesting that you bring this up now, because in talking to Michael and Tracy, we're going to be planning a boot camp for charge nurses and managers in order to support their growth and development, as well as the nursing directors. So we have a lot of great plans, and once we're recertified and we have the bandwidth to get really down to the nitty gritty, these are the things that are going to make Laguna Honda sustain the gain that we've made over the last year and a half.
Well, thank you. I think we'd love to hear updates on how these positions in particular are being filled and sustained. And I see our new nurse managers on their first day. Welcome, Ms. Brown and Mr. Collins. Am I right that that's who those are?
There they
All
are.
right, based with a mask on. We can still recognize you based on your pictures. We're absolutely delighted to meet you. Beautiful. Nice to meet you. Thank you.
Thank you, Dr. Green, and I add my welcome to our 2 new very, very key members of the management staff, and I'll wish you all the best luck as you progress forward. Thank you. No other questions or comments. We can move forward.
All right, thank you. We can move on to item 6, the Regulatory Affairs Report.
Regulatory Affairs Report. Good evening, Commissioners. My name is Geraldine Mariano, Director of Regulatory Affairs, and I will be sharing the Regulatory Affairs Report for Laguna Honda. Mark, are we showing the Regulatory Affairs Report?
No, we don't show it. We just talk about it, yes.
Okay. So the report reflects activity for the month of September. There were 11 facility reported incidents to CDPH, and we had 1 unannounced visit from CDPH for September to investigate an anonymous complaint. Laguna Honda is still waiting for recertification survey. Please let me know if there are any questions or comments that I can address at this time. Thank you.
Thank you, Ms. Mariano. Are there any public comments?
Yes, we've got 2. Let's see. Caller, please let us know that you're there.
It's Dr. Palmer again. This report shows that CDBH continues to be quite impressively missing in action in terms of following up, which is especially disturbing in cases of abuse. And how is that being dealt with? And can anyone tell us anything about it? I mean, it sounds like we have a State Department of Health that's not functioning. Thank you.
Great, thank you. Caller, you're unmuted. Please let us know you're there.
I am. It's Patrick again.
Please begin.
Thank you. Comparing the regulatory affairs reports issued during 2022 to the first 9 months in 2023 shows there were 3 more adverse event FRIs and 6 more injury of unknown source FRIs in 2023 compared to 2022. As I mentioned, the monthly quality affairs reports show that Laguna Honda had 3 more disease outbreak FRIs in 2023 than in 2022, and we're only 9 months into the year. Similarly, Laguna Honda had reported 5 staff to resident neglect FRIs compared to 0 in 2022. In 2023, Laguna Honda had 4 more major injuries FRIs than in 2022. In 2023, Laguna Honda had 3 more adverse event FRIs than in 2022. There were 2 more potential privacy breaches FRIs than in 2022. These total 23 more major FRIs were reported in 2023 than in 2022, and we're only 9 months into these reports for the fiscal year, or for the current calendar year 2023, which portends by the time we see the October, November, and December regulatory affairs reports, all of this data is going to get substantially worse despite all of the quality improvement efforts Laguna Honda has made to satisfy CMS, and it portends poorly for not only recertification, but on eliminating substandard care patient violations based on facility reported incidents alone. Thank you.
All right, that's the last comment for this item.
Okay, thank you. Thank you for your report. Let's move on.
Oh, great. We can move on to item 7, the Behavioral Health Improvement Project.
Hi, thanks so much for having me here. I'm Nita Ratana-Wangza. I'm the Interim Chief Medical Officer for Laguna Honda Hospital, and I'm really just so grateful to have the opportunity to work at Laguna Honda. It's been really just a gem of our health network, and I feel so fortunate to be able to be there. So today I'm going to be presenting information to all of you about our Behavioral Health Improvement Project, and I want to give a lot of appreciation to Dr. Yifang Chen, who helps co-lead this project with me. Next slide, please. Today, I'm going to be describing some of the reason and background for the Behavioral Health Improvement Project. I'll describe some of the progress that we've made to date and some of the tasks that we've achieved, and then our proposed plan for both our short-term innovations as well as our long-term work in this area. Next slide. So starting with the why, the reason and background for this project. So Laguna Honda cares for residents with complex medical as well as behavioral health needs. And so if you take, for example, a person who's had a stroke and is coming for skilled nursing care for that stroke, they may have underlying vascular dementia, which affects their neurocognitive function. They may also be struggling with depression, having had a stroke as well. And so it's really important that a facility that cares for residents with both medical skilled needs as well as underlying behavioral health needs is be able to provide the care needed to provide that tailored, individualized care planning. And so if you see here in 2021, roughly 3/4 of Laguna Honda residents were diagnosed with also underlying neurocognitive disorders like dementia or Huntington's disease with behavioral disturbances, mental health disorders like depression, as well as substance use disorder. Next slide, please. If you compare where we were in 2021 with where we are this year in 2023, I would say the overall information is that we have fewer residents with underlying behavioral health diagnoses compared with 2 years ago. The numbers have gone down in both overall behavioral health diagnoses, neurocognitive diagnoses, or coexisting neurocognitive and mental health diagnoses. And we really have about 8% of our residents now who have underlying substance use disorders. That is excluding tobacco as a substance use disorder, which we all care for as primary care clinicians. Really focusing on other substances as we think about this. Next slide. So as part of our root cause analysis, working with our key leaders in Laguna Honda, our key leaders across the San Francisco Health Network, as well as our colleagues coming in from consultants and area facilities, we really wanted to do a root cause analysis to see how we can do better in caring for our residents with behavioral health needs. And our staff voiced the need for more education and support on these topics, including topics of mental health care, substance use, de-escalation trainings, and then working with residents with challenging behaviors. For example, somebody with dementia who has a tendency to try to leave the facility, for example, how best do you help de-escalate the situation and provide supportive, gentle redirection in a way that works for that particular individual. And they really wanted training that goes beyond just taking an online module, but really gives them the opportunity to practice those skills and develop proficiency with this. So we worked with subject matter experts in February and March of this year to really look at what those best practices are in both behavioral health delivery redesign as well as education. We brought in experts from other neuropsychiatric facilities, geriatric facilities, and long-term care, our colleagues in behavioral health services, as well as our consultants for recertification. And in response to this work, Laguna Honda leadership created a work plan to think through the necessary changes in how we provide behavioral health services, as well as how we provide education and training to our staff to provide care for residents who have underlying behavioral health needs. Next slide. So the work has been divided up into essentially 3 work groups. One group was focused on training and education and identifying the gaps in our current training and our strategy, thinking through how to provide comprehensive support in these topic areas for our staff, and thinking through what are the things we could do to redesign that curriculum and the way we reinforce that to help ensure proficiency in these skills. The second group was the redesign work group, focusing on looking at what are examples of excellent care in caring for residents with behavioral health needs, conducting literature review and site visits to see what our options were, and to look at how we can refine our admissions process to make sure that we're screening appropriately for what we've said in our policy 20-01 about how we're really looking to see that we match our skilled nursing facility level care to those who have the right fit for Laguna Honda services. And then our oversight work group is really our executive team, looking and seeing what each of these groups has developed and assessing and escalating to help with providing the resources necessary to do the work. In the end, we decided to combine the education and training work groups with the redesign group because so much of it is an iterative process working together. Next slide. So I'm going to describe first to you what we've accomplished so far in just these last few months, and then I'll describe where we are heading with our short-term and long-term plans. So our first is in our education world. We've been doing a lot of trainings, and you hear a lot about trainings in these topics. And I think I want to emphasize that we're doing in-depth, in-person, practical trainings with all our staff. There's a 4-hour training that combines learning about de-escalation techniques and practicing those, as well as how to care for residents with substance use. We've trained over 600 of our staff to date with a goal to get to over 95% by the end of October. When I took this training myself, I really found it was just a wonderful way to work across care team members to really learn about what is it that you experience on a day-to-day and how can we help you to be able to practice that. The second major accomplishment I would highlight is one you've already heard about here, which is our behavioral response team or a therapeutic care team. It's known also as BERT in shorter lingo, but it is essentially a group that is engaging at the bedside and with the care teams across all the neighborhoods. They're staffed now 7 days a week to provide care and go to the bedside and go work with the teams when there's an issue, such as, for example, a person with dementia who is trying to leave the area, helping remind folks about what are the strategies that are most appropriate to help redirect that person back in a way that works for that particular individual. And then helping to care for the staff at the side to make sure that they are doing well themselves, because it can be very stressful in working on these topic areas as well. So that's a major accomplishment, and a lot of appreciation to Shannon Bevitt for the work that she's done in this area. Next slide. In addition, we are recruiting providers and care team members with behavioral health expertise. We've been really fortunate to be welcoming in a new addiction medicine internist who is coming to us from our colleagues at UCSF and ZSFG. She is a trainer in fellowship and in residency for those with addiction medicine, and she will be coming to lend her expertise not only as an internist, but also to help with thinking through how to really integrate across all the care team members we've been describing before. We've brought on several new psychiatrists, including a public psychiatry fellow who started this year, and brought more of our colleagues from behavioral health services to help with providing the care on call. We brought a full-time behavioral health clinician to join our team starting in June. And as I mentioned before, our therapeutic care team is now fully staffed with 7 days a week care. So that's been a wonderful thing, because that helps to spread the care for folks who may not be wanting to engage in direct one-on-one counseling yet or in support groups, but who needs to get that care from people at the bedside from their regular care teams. And this really helps integrate that across all of the care team areas. In addition, our work groups are working on developing the methods for sustainable long-term solidification of the training and education we've provided so far, and working on the metrics to assess the short-term plan and long-term success. Finally, in our redesign work, we've been looking at the admissions screening process to make sure that we know the best practices for assessing our residents who have skilled nursing needs, to know what are your behavioral health needs, and is this the best fit for where we can provide that. We've done literature review to look at models for focus units for residents with behavioral health needs. And we conducted a site visit to an area facility in our East Bay that has actually successfully implemented a focused unit to look at how they both admit residents, train their staff, and provide long-term sustainable support to their care teams there. So based on all of this work to date, we have been working on developing a short-term plan, which I'm going to present to you, and then our direction for our long-term plan. Next slide. So our short-term plan is to really focus on the test of change with pilots on 2 units, and that will help solidify both the training methods as well as the strategies and implementation for a longer-term plan for a potential focused unit. So our short term is working with these 2 units to identify their 6 residents with complex behavioral health needs, and then identify the 12 staff who are working most closely with those residents. We've created a curriculum for learning circles, which are essentially in-person small groups to hear about the day-to-day strategies that they're working on, to see how they're implementing those, and to help teach what's called nonviolent communication strategies, which is another technique for communication in these situations, and to make sure that those are integrated into the care plan and handed off from these experts to their other care team members, shift to shift. The teams are actually very excited to begin this. We started working with them recently, and they're really hungry for this kind of support because they want to provide the best care for our residents and are excited to learn more about how to do that. Next slide. our metrics for this process, we want to see, are we doing well with the work that we're doing? So we're going to look at some process measures that include looking at our staff competency and proficiency, and how much they're engaging with the short-term plan in terms of the learning circles and implementing those, as well as outcome measures. So we want to see what is the impact to actual resident experience and resident behaviors. Can we see a reduction in certain things that we're always trying to reduce? For example, episodes of code green or residents attempting elopement, or episodes of having to call for security, or episodes of other things that may happen that get reported into the unusual occurrence or UO system. And of course, we want to look at resident and caregiver satisfaction. So we want ultimately to make sure that this is something that is resident-centered, trauma-informed, and supportive of the goals of our individual residents. Next slide. In addition, we're also putting in a pet robot project. This is something that I believe was also implemented at San Francisco General as well. And the purpose of this is, again, we're thinking through dementia as one of our underlying neurocognitive disorders that is commonly seen among our residents. This is something that can lead to loneliness and boredom, and those can be then triggers for behavioral escalations. So one of the key things to help with is to be able to help provide companionship and support, and pet robots have been shown in research to be helpful in that regard. So we have 10 pet robots, 5 dogs, 5 cats, so that we're fair across people who have different preferences, and have distributed them to 8 of our residents. And again, it takes a village to be able to roll out work like this. And so it's a really collaboration across, AT stands for activity therapy, our social work teams, primary care physicians, neuropsychologists, and we're working on metrics to be able to measure the success of this particular project as well. Next slide. So then the question is, where are we going long term? And I think that there's a lot of talk about the potential advantages and also challenges of having a focused unit. So if you have, for example, a set of residents who have neurocognitive disorders like dementia, is it better to have them across all of the units, or is it better to have them in one focused unit where there are people who have special expertise and strategies who can be able to help and provide that tailored care because that is their focus area? And I think in both our literature review as well as our site visit to a facility that provides that kind of focused unit care, I think that there are real advantages to this. So for example, the ability to implement treatment recommendations and immediately and do just-in-time support for those to make sure that those are being implemented. To think through focused selection and hiring of staff who have that expertise and that desire to work in that area, and then to be able to tailor the activity programs and other supports for those focused needs. I mean, disadvantages or some of the challenges with doing that immediately are, we have to think through what is the right staffing model there. And you want to make sure that you provide not just the support for that focused unit, but for the residents who have needs across the facility, which, as you saw from our earlier slides, there are many and they're heterogeneous. The idea of transferring a resident who has neurocognitive disorders or other underlying behavioral health needs from their home unit into a focused unit could trigger challenges for that particular resident, and we don't want to be doing that. So we have to be very careful about thinking about things like relocation. And then there are multiple identities that a resident has. They are not just a person with dementia or depression. They are also a person who speaks Spanish potentially or speaks Cantonese. And so there are advantages to being in units that serve those identities and help them with those. And to some extent, some of that may be the most helpful for their needs in behavioral health and their social support. And then we really need to be thinking through, like, how would this actually be implemented as part of the admissions process? And so I think the work that we do in the short-term plan really helps to inform our processes as we move forward to see, can we set up a focused unit that really makes sense using the educational strategies and support model that we think will be most successful from that pilot. Next slide. So some of the challenges that I've spoken about some of them, the idea of what's the location and what's the best way of setting it up to meet the needs. How do we best fill the staff needs and skills that we have and build those programs? And then the overall and always goal is really to balance our meeting of SNF regulations and where we are with our journey to meeting residents where they are. And the good news is that we feel very confident that we can do this, and we can meet SNF regulations and provide excellent resident-centered care to a community of residents who have underlying SNF needs and who also have underlying other needs as well. So I'm going to give you one case example to end on to describe this. Next slide. This is an example of how we've provided care for someone with an underlying behavioral health need. So this is a resident who has SNF level needs and a longstanding history of stimulant use disorder. And after they were admitted for their medical SNF level needs, a resident was referred to psychiatry for assessment, who evaluated them and suggested enrollment into the SUD treatment program at Laguna Honda Hospital. The resident was enrolled and quickly became an active, engaged participant in those services, complied with the care plan, got along really well with other residents, and really had no behavioral disturbances. But a few months into the program, the resident relapsed and accidentally overdosed. Fortunately, staff discovered the accident, provided naloxone, and saved the resident's life. And the resident was transferred to the emergency room for stabilization and care. And when the resident returned to Laguna Honda, they were really grateful to the staff for being able to provide that quick intervention, and really felt motivated to reduce their substance use and to work on change. They began really engaging additionally with the substance use treatment programs in both group and individual counseling, and they're presently in remission for their substance use. They were able to achieve their clinical goals, have resident-centered care delivered, and have the best practices implemented for harm reduction to improve their health. And the resident really expresses a great deal of appreciation for Laguna Honda for the care that we provide, not only for their SNF level needs, but for their entire well-being. The resident said, "This place has saved my life, and I would be dead if it wasn't for this hospital." So with that as one of our inspirations, one of our goals, I'd be happy to take your questions and comments. Thank you.
Okay, thank you for your presentation, Dr. Tanawansa. So are there any public comments?
There are several. I will unmute the first one. All right, please let us know that you're there, caller.
Hi, this is Dr. Palmer. I think it's kind of disingenuous to mix up patients with dementia who may elope or may need to be stimulated in a special way from with patients with active substance abuse. Laguna Honda has a lot of experience with focus units for dementia patients who are in elopement risk. It's had secure wards where these patients have been cohorted for many, many years. And the one case report you have is someone who has a problem with stimulant abuse but ODs on opioids, and is really a nice guy, but how does he get, are the drugs that he's using available to demented patients that might get into his stuff? And how did he continue to stay at Laguna Honda if he's actively using substances on campus and ODing? And this is a huge problem in a congregate living facility, and you've managed really not to address it in this presentation. I'd like to hear a little bit more about how this is going to be dealt with realistically. Thanks a lot.
All right, thank you. And there's one more caller. Caller, you're unmuted.
Yeah, good afternoon.
Oh, I apologize. Oh, start again, please.
That's me again.
Oh, I apologize. Hold on.
You can take my.
Mr. Minetshaw, I apologize, and you've got 3 minutes.
Apology isn't necessary, but thank you. The increase of 27 patients in 2021 to 47 patients in 2023 who had no behavioral health diagnosis seems quite odd. The two-column table on page 12 lists advantages to having a behavioral health focused unit. 3 of the 4 advantages accrue to staff, not patients. Likewise, 4 of the 5 disadvantages accrue to the detriment of patients. Aren't those 4 disadvantages sufficient enough to kill further discussion of creating a focus unit to cohort and segregate behavioral health patients into? Don't those disadvantages run counter to providing resident-centered care? Don't the disadvantages speak to not providing behavioral health patients with the quality of services they deserve? And do the 4 disadvantages fly in the face of CMS's Phase 3 regulations to provide appropriate health services within a SNF? The behavioral health presentation presented to the Health Commission last week dealt predominantly with overdose efforts across SFDH, not behavioral health programming at Laguna Honda or elsewhere in the city. Pickens appears to have told the Board of Supervisors during the Committee of the Whole hearing on September 26th that the Health Commission would be presented with a fuller and more robust behavioral health facility needs analysis focused on expanding the number of behavioral health bed capacity in San Francisco that was supposedly underway by a separate work group, which it doesn't appear that that work group prepared today's presentation. So will a broader behavioral health work group report be delivered next week to the full Health Commission meeting as Mr. Pickens had promised the Board of Supervisors? When are we going to see what efforts the DPH is making to locate more skilled nursing beds for behavioral health patients?
Your time is up, Mr. Manetchal. Thank you. And those are the only 2 comments.
Okay, thank you. Comments, questions?
Yes,
Dr.
well,
Green?
first of all, thank you. It sounds like you've done a lot of complex and advanced thinking, and I think it's terrific also all the research that's been done in the site visit. I was wondering a few things. Do you have any sense of timetable here, both when you'll know the outcomes of some of these projects, like the PET project, and when you might be able to collate the learnings from your short-term plans to really develop and initiate a long-term plan?
Sure. So I think that we expect that we would have initial, outcomes at the sort of resident level by early quarter one of 2024. So we're just starting with the pilots right now, but I would hope to be able to turn around to you some preliminary information as soon as we can in a few months. I think in terms of the longer term plan, I think that we would be integrating our learnings from that immediately into solidifying what would be a longer term plan. So we're not going to wait until all those metrics happen, but we want to really be thinking about as we go forward. And I think that's one of the other wonderful parts about bringing in the long-term leadership for the hospital. Our nursing home administrator leaders, as well as our new directors of nursing, really have the expertise, I think, to help us to solidify and translate some of these short-term projects into the longer-term sustainable plan going forward. Apologies about my phone. Sorry, that's the pickup from my son reminder usually. So.
And well, thank you. And then does our new nursing home administrator have any opinions or experience in terms of defined units? Because from what you're saying, in theory, you could have new admissions, for example, especially if it's a dementia diagnosis, go to a specific unit if you didn't want to, for example, displace the people that were already there. And so I'm wondering whether in the insiders and maybe, your new additions to the management staff may have some experience as well, but do you have any sense or any just feelings from everyone you brought on board, that, including our HSAC people, in terms of what to do when you look at column A, column B, pros and cons, and if it were decided that we would have a defined unit either for substance use disorder or dementia patients or depressed patients or whatever you choose, how long it would take to actually develop that unit? Can you pull people from different units who already have some expertise, for example? What do you think would be a timeline for something like that?
Yeah, I think that it is important to examine that as we start to think through the admissions process, because of the challenges of relocation or the sort of, and I think thinking through what the advantages of a focused unit really come from a more homogeneous sort of designation. So not just saying someone has underlying behavioral health needs, but really what are those, and are they in a focused way able to be met in a particular area by a particular group of staff? So I think that what we would do as part of this admissions planning process would be to really be thinking about, now that we have some flexibility in where folks would go, how can we be thinking about putting them in a location that makes the most sense for their needs? And again, working across the network with our partners across places to really be thoughtful about, is this the best fit for them, where they need to go and where they are with their needs? So, but I think that the great thing about, for example, Sandra Simon is she has great experience about thinking about creation of focused units in her prior work. And I think that we would work very closely to continue to learn lessons from the work that they've done in those other facilities.
No, I'd be really interested to hear, now that everyone's nearly on board, what they would say about focus units. The other question I had was about the substance use disorders, and it's encouraging that the numbers have fallen considerably in terms of the number of individuals. But I know we've heard that it's been frustrating. You can't force people to go to group, et cetera. But what would be their relationship to our new mental health providers? In other words, if they just put, just say, I don't want to see someone like that, what are our options, including at what point are they just not appropriate for the facility? And again, when there's certain numbers of violations, at what point? I mean, I think in some of the new policies, there's some issues about finding contraband, and how many times can someone be in that situation and still stay at Laguna? So how will we kind of adjudicate all of that? And is there something about this program, short-term or long-term, that could help those remaining individuals with substance use disorders be more carefully counseled, or perhaps, follow the outcome of the individual described at the end of the presentation?
Of course, of course. So one of the things is that, and I come from a background in primary care, right? So there are many people in primary care, for example, who are caring for people with substance use disorders, many more than our patients are in substance use specialty care, right? And so there is a need to ensure that even if you are not that focused psychiatry provider or that addiction medicine internist who has that expertise, that you can speak to and help counsel and bring into through motivational interviewing, through brief intervention, that bring people to where they need to be, or where we hope that we can help them to be in terms of safety and in terms of their goals. And so I think the more we can do with through the therapeutic care team with a consult service started by the addiction medicine or psychiatry folks, the more we can help engage people, even if they're not willing to yet be in substance use focused treatment. And the way they do that currently is that there are emotional support groups that people can drop into. It doesn't have to be that they are coming to engage about their substance use, but they can come and engage in other forms of social support and expertise, and then get to know people, build trust, and then move forward. Same with the therapeutic care teams. They're there at any moment when somebody is in need, to be able to help find that opportunity to help bring people to change, to find the change talk opportunities, and then to be able to get them to the place so that when they're ready, they're able to engage with the specialty care services that we have. And so I think it's about making sure that everyone can seize on those opportunities whenever they may come. At the same time, our paramount top priority is to ensure the safety and security of all of our residents, right? And so we really are taking seriously, here are the policies, here are the rules, here's what we need to do, how do we make sure that everybody is safe? And again, I bring a lot of credit to the folks who are, both the people who have been here working in incident command, but also to the new folks coming in who are really bringing that expertise to how we can do this in ways that are resident-centered, as well as follow SNF regulations, because that is very important. And I do believe that we can do that. And I think we owe it to anyone who we're considering bringing in to Laguna Honda, to be totally transparent about what we can provide and what is allowed, right? Because we do have conditions of admission. And for some of my patients that I care for at San Francisco General, they may not be the best fit to come to Laguna Honda Hospital, depending on where they are with their journey. And there may be wonderful facilities that we have in primary care and in behavioral health and other places that actually are a good fit and can meet them where they're at. And so I'm really confident that if you think about it across the whole network, that we can find a place that makes the most sense for a given individual. And I think we owe them that, to be upfront in advance, to make sure that they choose and that we choose in the right way so that we find the best fit for where somebody is. And I think that that ultimately is most important to that resident, right? Or that patient or that client, depending on the word and where you are in the health system, because we want that person to find the services that best meet their needs and where they are.
That's really heartening to hear, because I know a lot of members of the public have been concerned that individuals have been admitted with a primary diagnosis of something like substance use disorder, and we know they have to have other underlying problems, and that cannot be the primary reason of admission. But the idea that we are really expanding our approach to try to find other alternatives, I think is going to be really important. I think we'd probably be interested in hearing, as you know, given the individuals you have now and given your admission policy should exclude a huge majority of these individuals, that the ones you have remaining, what these advanced techniques and individuals that you're bringing on board can do to help more people end up in the story that was a success story. And I think us understanding the numbers would also be very helpful too, as you progress. That would be, you know, one of the incredible metrics for the success of all this work that's being done. So yeah, thank you very much.
And I believe Dr. Horton would like to say something, if that's okay, commissioners?
Yeah, if it's to Dr. Green's questions, because I had a couple of other questions, unless Dr. Horton, you have new information to share, or until, because my questions sort of relate to what Dr. Green's questions were.
I was just going to tack on a quick thing to Dr.
Okay, great.
additional response, if that's all right.
No, that's great. Thank you.
Commissioner Green's question. Just wanted to say, and this happened a little bit before Dr. Ratana-Wangza came on, but very much informed the formation of the BHIP committee, that the question about whether or not to move towards a focused unit, we did actually, over the winter, we had a pretty robust series of focus groups where we asked a number of experts to kind of come to the table and really help us think through some of the options before Laguna Honda. And these focus groups included, you know, experts in the field of skilled nursing facilities, but also behavioral health care facilities, including the leadership of Crestwood, and also just leaders in the field of, you know, behavioral health and substance use disorder treatment. And one of the questions we specifically put before the focus groups was the question of Laguna Honda moving toward or not moving toward, you know, very defined, focused behavioral health units. And there was a literature review as well. And I think, one of the things that really emerged, and we also looked at Laguna Honda's own history with having more focused units. And one of the things that were emerged that was that this is really not a slam dunk answer to this question. And I think that informed, you know, what Dr. Ratana-Wangza presented in that slide about the pros and cons of moving toward a focused unit. So I really appreciate what the Behavioral Health Improvement Project group has decided to do, to take a very thoughtful approach and piloting some elements of of having a focused group of staff that really receive these trainings and really determining what is the right path for Laguna Honda. So in addition to having wonderful folks like Sandra Simon and Diltar on board who have this richness of experience, I did want to say that we, you know, did have a pretty robust process to help inform our work going forward.
Thank you, Dr. Horton. I really appreciate your additional comments, because that just sort of rounds out what I think were excellent answers by Dr. Ratana-Wangza to Dr. Green's questions that sort of cover where I was going as well. But my first comment is it really does make me really appreciate the expertise that we have been able to bring into Laguna Honda, not just around the behavioral health, but this is an example of really sort of a new way of sort of an enterprise approach to the residents in San Francisco that need our help across a spectrum of health issues, from prevention to, to, acute episodes to, long-term care, to all kinds of things that I think represents a true network, right? So I really appreciate that. And it's being demonstrated, I think, just in this short presentation and discussion. So the question sort of related to that was around the care team. We've heard a lot about the care team on the sort of general side of, the kinds of things that are needed around that. But now with this element of the behavioral health, both the short term and the long term, what will a care team really look like, for those residents that either are being admitted or being considered for if we decide to do a focused unit? And you've alluded to that, you've sort of described it a little bit, but how will that be formed different from those residents or patients that don't need the behavioral health part of the care team?
And I think that the disciplines that are involved in the care are very similar across both, and I think, again, that's one of the wonderful things that I've learned about coming to Laguna Honda Hospital is how every member of a traditional skilled nursing team has a role in thinking through and coming up with best strategies for reducing challenges with behavioral health. So, for example, in one situation that I'm thinking about without giving any personal health information, somebody who may have a tendency to leave or be combative because of their with some underlying dementia. And in a resident care team conference, the voices that come forth are not just nursing and medicine and neuropsychology, but also, activity therapy and thinking through what are the strategies this person likes. Well, they happen to have a particular area of focus in the arts, and what they're struggling with is that they can't physically hold the implement that they use to perform their art. And what is it that we could be doing as a group to think through the activities or the individual adaptive device that would allow that person to engage in their art again, or maybe even to teach art because they don't want to be coddled or be entertained. They actually have real expertise and they can still teach to it even though they have underlying dementia. So I feel like a lot of those individual disciplines are the same groups of people. It's activity therapy, physical therapy, occupational therapy, social work, and psychiatry and medicine and nursing all together, right? I think that behavioral health team, the therapeutic care team, is really a key to sort of solidify then, what are the recommendations that come out of that interdisciplinary care team, and what are you doing every day to reinforce that from shift to shift when that person may have some challenges at this time of day. It's always a really hard time. How are we handing it off to the other person? So I think there is bringing in of expertise, but the disciplines and the makeup of the care team are the same. I think it's maybe a question of, are there particular activity groups that are best suited? I think Laguna Honda does have a lot of expertise in figuring out some of those group activities that can be programmed in and can be led to really tailor to a larger group of people altogether. So I think that there are some programmatic activities that might be very good on a focused unit that would be key. And then how you manage key things like smoking activities or things like that. Those are some of the lessons we learned when we visited a site like Crestwood about how they manage incentivizing positive behaviors and reducing less positive behaviors. And so I think there might be some particular programmatic elements, but they would be layered on likely a similar type of staffing. And you might bring on people who have more focused psychiatric nursing types of expertise down the road, but I think that what I learned was that you can really provide support to folks who are in the traditional skilled nursing sort of background without additional layers of degrees or training necessarily.
And how will this be captured sort of in a care plan then? Will the electronic health record be able to capture all of that? Or is there, sort of some sort of innovative ways that we're going to be able to document? And because I know that we want to do this for the individual resident or patient as needed, but we also, I think, want to be able to learn. I mean, you said we want to learn from both the pilot and potentially the long-term programs so that, going down the road, we can continue to innovate and adapt as needed.
Yeah, well, in my previous life, you may know that I'm a big proponent of documentation and electronic health records. And so I think it's actually crucial. And one of the key things that I love about our nursing home administrator leadership team is they really are emphasizing, is in the care plan, isn't in the Cardex. Where would people who are there caring for a person look to see and know what it is? And it's not just about knowing this is what you should do because this is following regulations. It's about knowing this individual and what works best for them. So how do you care plan out? And what I'm finding in many regards is actually our care teams do know our residents. They know them very well. And it's really a question of highlighting among the many issues that they're helping care for, whether it's their need for a splint or their need for oxygen. But where do you put that key part in there about at this time of day, the resident really misses this, and thinks that this person's here and really needs, or this person has a craving for cigarettes at this time of the day. How do you help best to sort of, to what are the quotes that you use? What are the strategies? What are the other things? We had a resident who had, and I know people are talking about dementia as being, but it's actually a pretty key challenging situation for a lot of our residents actually. And their care team members, when they were coming back from acute care after being in psychiatric facility, said, he really actually likes to build and sculpt with his hands. And so let's get some Play-Doh here and make sure that it's there welcoming him when he comes back, And so I think that those are the kinds of things in the care plan that we want to highlight. And as well as helping people with that positive framing. I'm also a mother, and so I think about this a lot when I'm thinking about how do I reframe everything and every feedback I have into the most positive ways so that what you're saying is always yes. Yes, you can do this, and I will be back in this time to do that. And so those are some of the great strategies we learned when we went to visit these facilities that we want to build into the care plans so that that person who's caring for a person at 8 o'clock at night can immediately look and see, this is what I say when that person asks me this question.
Great. Well, again, I'm looking forward to hearing more about how this pilot is progressing and how we'll move, if needed, from the short term to the long term. Because I would imagine both with the challenges and the information that is going to be gathered, though it might look quite different, as we move past January or the first quarter of next year. But
Yes.
Thank you for your presentation. Again, thank you for your work and dedication.
Thank you very much.
All right, we can move on to item 8, which is an action item, Laguna Honda Hospital policies.
Okay. And again, as we have been doing over the last several meetings, because of the volume of policies that we're being asked to review after the hard work of staff in both, just reviewing themselves and implementing and taking ownership of these policies. And then with the short week, this past week, we are going to request, first of all, if there's any immediate comments from any of the members of the committee, and then a similar process that we've had over the past couple of months. So let me go there first and see if there's any public comment first.
Well, actually, Carmen may have some responses to some of the previous. Is it okay if staff speak to things that were turned in to see if we've got any comments from them?
Oh, sure.
Got a public
Yeah,
comment?
that would be fine. Okay.
Great. Carmen or Naz or anyone, are there responses?
Yes, there are. Let me just open up the document real quick.
Carmen, can you speak up a little bit, please? Thank you.
Okay, this is better. So for policy 2205, theft and loss, the question was, how can staff inventory newly obtained items when out on pass resident refuses? The statement, the resident shall have a reasonable opportunity to dispose of the property, or the property shall be inventoried by staff, is at odds with respecting the resident's refusal to property inventory, and may violate phase 3. The response was, this statement is to suggest that they will provide an opportunity, and if they decline, then it will be documented. There will be no force or requirement. For 2418 resident locator system, question is, do any residents have the equivalent of a medic alert medallions? And the question is, the answer is no, none of the residents have that. And the last one I got a response on is with smoking, 7602. The question was, will phase 3 regulations allow repeat searches without consent? The CMS State Operations Manual does not permit searches without consent. The resident may provide consent. Expulsion is not an option. The facility must ensure a safe discharge even in the instance of non-compliance. When residents are not compliant with policy, they receive a patient safety contract, re-education of facility policies, and review with the care team on new interventions that can support the safety and well-being of the resident. If and when able, the facility does review potential discharge to a safe location. Those are the responses I have for now.
Thank you. Any additional, let's see if we have public comment.
We just go, yes, there's one person public comment, then we go to questions. Okay. I see one hand. Caller, I've unmuted you. Please let us know that you're there.
Oh, hi, this is Dr. Palmer again. I'm especially worried about the coach use for close observation policy 2410. It's extremely important that this policy be tightly written and that the responsibility for assigning a patient one-to-one supervision, which is essentially what a coach is, not be too diffuse or too complicated. One of the things that happens is when a patient is acting out and the facility is understaffed, there's a lot of pressure, not for the MD or the head nurse to not assign one-to-one, even when one-to-one is really unnecessary and will protect either the resident or other residents and the staff from danger. And I myself, when I was working at Laguna Honda, got called before my bosses for insisting on a one-to-one in a vigorous patient that beat up a frail patient on the dementia unit in the bathroom, and there was clearly not enough staff to watch this patient. But there wasn't. But because of the staffing shortage, nursing didn't have anyone to supply, so they wanted me to withdraw my order and not document that this was necessary. And I think it's really, really important to have a tightly written coaching where staff that are acting in the best interest of the patient and other staff will not be retaliated against for insisting on a coach. And this sort of vaguely the RCT will decide. I think, for one thing, if an MD orders one-to-one, that should be honored, and that should be allowed. And there are times when, even if it's inconvenient for everyone, a coach has to be called upon. And especially if you're talking about admitting and continuing to have behaviorally complex residents. Thank you very much.
All right, that is the only public comment on this item.
Okay, thank you. Any comments from Commissioner Green?
Yes, well, I apologize, first of all, for not getting my questions in sooner. And I think most of them are more elaboration, looking at it through the lens of someone who doesn't work there and so doesn't really know all the protocols that are in place. And it's hard to put all these things into words. So, I apologize not only for being submitting this, not realizing Monday was a holiday, but also, some of the detail. But I'm happy to move that we approve these policies pending some answers and approve that they be taken to the Health Commission as a whole.
Okay, is that a motion then? Second?
And all those in favor?
Yeah. All those in favor? Aye.
Great.
Okay.
Thank you so much, Carmen. All right, we can now move on to a consideration for a closed session.
Move we go to closed session.
Okay, second. All those in favor?
Well, actually, before you vote, I'm sorry, let me just call for public comment. Any public comment on consideration for a closed session? Going once, going twice. Okay, no public comment.
Okay. All those in favor?
Aye.
Aye.
Great. Thank you so much, folks who participated from the public. We will not be seen or heard while we're in closed session, but we will be back after the closed session to close out the meeting in the open session. And I'm going to start the closed session right now. Actually, give me 1 second. In session, commissioners, please consider a motion to disclose or not disclose discussions held in closed session.
Move not to disclose.
Second.
All those in favor?
Aye.
And now please consider adjournment.
Move to adjourn.
Second. All those in favor?
Aye.
Thank you, everyone. Have a lovely evening. Be safe.
Thank you.
You guys are so terrific.